PowerPoint pulled up here. Today, our webinar is 1 hour in length, 60 minutes. We are glad to have you with us. We do want to remind you of a couple of housekeeping items. If you do have anything that is open on your browser or on the internet besides the webinar, you might have some cutting in and out. So we recommend that you close anything, including email programs and things like that. We do have a certificate of attendance that we will be sending out to you in the next 2 to 3 business days. And we encourage you to take that attendance, certificate of attendance, and if you are submitting it for CEU credit, you would do that to your licensing organization. We also are recording this webinar, and it will be available on our website at efmn.org within a few days after the webinar. So that's our housekeeping items for our webinar. If you want to ask questions throughout, we will take us time at the end, about 10 minutes for official Q&A, but we do want you to know that there is an opportunity to type in your questions at any point. We have 3 speakers today, and so you might have questions throughout. At the bottom of your screen in the middle, there's a box or a button that says Q&A, and that you can open up just by clicking on it and type any question you have at any time. And we'll be monitoring those questions and answering them at the end of the webinar. Again, I want to welcome you to this webinar on epilepsy, autism, and attention deficit disorders. My name is Amy Haugen. I'm the Regional Program Manager at the Epilepsy Foundation of Minnesota. I'm located in St. Cloud myself, where my office is, but serve all of the outstate regions of Minnesota. We also have Ellie Wilson, who's the Executive Director at the Autism Society of Minnesota, and Lee Garrows, who's the Research and Development Coordinator at the Attention Deficit Awareness of Minnesota. We're very excited to have these 2 women with us to bring expertise on their areas of where they work. We're going to talk today about some objectives first, so you should know what you're going to get out of this kind of webinar. There's 4 basic objectives we have: learning basic epilepsy facts and statistics. So I will start our webinar out with some of that information, and then I'll turn it over and so that you can gain some knowledge about attention deficit disorder and autism. And then we hope that you will increase your understanding of the relationships between these 3 disorders. Some of the statistics you'll hear will bring that to light as far as how they can be related to one another and how often they occur in tandem with one another. And then we hope you acquire some helpful tips to recognize behaviors that are common in all 3 of these diagnoses. We're going to start out, however, just gaining some knowledge from you about your level of knowledge about these 3 disorders. So we're going to go ahead and open our poll. And that poll is just one simple question. You should be able to click on your answer. And the question is, how would you rate your level of knowledge about any of these 3 disorders? And so if you feel like you know very little about those 3, you know a lot about them, or you know a fair amount about some, but not so much about the others, please feel free to take the time now to answer that question. And I see that we're in progress, and we are about halfway there with our people that have registered their answers. And then we really just want to know from you where you're at, whether it's because you have someone that you know, love, take care of that has these different disorders, or you're gaining more knowledge from a professional standpoint, all of those kinds of things. We'll take just a few more seconds to finish out that poll. If you haven't voted, you should be able to just click on your choice for that question. We're going to go ahead and close out the poll and see what our results are now. So it looks like we are sitting with many of you knowing a fair amount about 1 or 2 of them, but not a lot about the 3rd or another one. So about 88%. So that's awesome. And some of you know a lot about all 3. So thank you for sharing your knowledge level. That helps us as we are presenters to know where we all are at with these. So go ahead and we'll close that poll results out. And we're going to start, like I said, I'm going to share with you some things about epilepsy and seizures, give you some of that baseline knowledge. Again, I'm at the Epilepsy Foundation of Minnesota, and we work exclusively with individuals who, and families who are impacted by epilepsy. And so what we know about epilepsy is that it is a neurological condition, so based in the brain, and it's characterized by unprovoked reoccurring seizures. And so some key words in there are unprovoked and recurrent, meaning that what we know about seizures is that 1 in 10 people will have a single seizure in their lifetime. That does not mean they have epilepsy. It means that they've experienced something in their brain that has caused their brain to misfire to the point of them physically having a seizure. And so that's 1 in 10 people. But in order to be diagnosed with epilepsy, we know that you have to have a reoccurrence of seizures. And so more than one usually will lead to a diagnosis through testing of an EEG, where they're testing your brain electrical patterns, or other testing like MRI and scanning that is done. Diagnosis also comes through the patient telling the doctor what they've experienced, or their family members or caregivers telling them as well, especially if a seizure isn't actively happening when they're at the doctor. So when we talk about epilepsy, we know that there are a few myths that are still out there. Those myths include that epilepsy is contagious, which we know is not true. We also know that epilepsy is not a mental health condition or a mental illness. We do have clients, about 50 to 60% of our clients who are diagnosed with epilepsy will also be diagnosed with a mental health condition at some point in their journey for several different reasons. And then we also know that epilepsy does exist on a spectrum. And when we talk about spectrum in the epilepsy world, we're talking about how are the seizures controlled? How are they impacting their life? And sort of what does their epilepsy look like? So we might have a client who takes one medicine for the one seizure type she has, and she drives, she works, and she has, self-reports a very minimum amount of impact on her life because she's well controlled. And we might have another person who's the same age, and she has 4 or 5 types of seizures. They happen every day. She takes multiple medications. She's had brain surgeries, and she doesn't drive and is not able to work. And so the impact is much different. She lives on sort of the other end of the epilepsy spectrum. We also know that seizures, a person will rarely die from having a seizure. The rare statistic that we use that we know of is 1 in 1,000 people who have epilepsy will die from something related to a seizure. When we talk about why do people have epilepsy, we know that there are many physical reasons, physical changes to the brain tissue, head injuries where there's bleeding in the brain or swelling of the brain, changes to brain structure through stroke where part of their brain has died. Those can all lead to changes in how the brain is able, the neuron cells are able to communicate, and therefore changes the way they communicate and leads to a greater chance of having misfiring. We know there are brain infections as well. We also know that in young people, oftentimes there might be an injury at birth, or their brain didn't even develop fully or normally in utero. We know that we also have certain components that are related to genetics. And genetics might mean hereditary reasons, but it also might mean DNA level sort of reasons. Things like mutations and deletions at the gene level that lead to certain epilepsy syndromes. So I tell you all those causes, and yet the biggest news is that about 50 to 60% of those diagnosed with epilepsy do not know why they have epilepsy. And so we have a huge portion of our clientele that we work with who are living with a disorder that does not have a known cause. To give you some prevalence and demographic sort of information about epilepsy, we know that there are 50 million people around the world who live with epilepsy. And active epilepsy, meaning that it is occurring, it is active, they're having seizures, or actively being treated for epilepsy. It's about 1.2% of the population in the United States. If you break those down into some of the different age groups, you can see here that children, almost 500,000 children, 470,000, and nearly 1 million people are over the age of 55. Those are our 2 age groups that have the highest active epilepsy rates. It occurs across all ages, but we know that children and those over 55 do have a higher incident rate. When we talk about how many people will actually develop it at some point in their lifetime, doesn't mean that it's at one given point active, but we know that 1 in 26 people will develop epilepsy at some point. When you look at this map, it's all different colors for reasons. The darker the color, the higher the incident rate, or prevalence rate, excuse me. And so when you see Minnesota there, we are lower than Wisconsin, but we are higher than North Dakota and South Dakota. Some of it has to do with actually our populations, right? In our part of the world, North Dakota, South Dakota have lower populations, have lower total numbers of people with epilepsy, whereas Wisconsin is a higher population and could have some influence on the numbers compared to Minnesota. Demographically, when you look at who is impacted the most, we know that there are different demographics we can look at, different races. So we know that 375,000 African Americans live with active epilepsy. We know 255,000 Asian Americans and 400,000 individuals of Hispanic background are living with active epilepsy currently. When you look at the commonality of it amongst the rest of the neurological conditions, if you will, it is the 4th most common. But when you look at how many people in the United States have epilepsy, it's twice the number of cerebral palsy, muscular dystrophy, multiple sclerosis, and cystic fibrosis combined. So it is a very common neurological condition that many, many people are living with. That gave you a broad overview of epilepsy and some statistics. I know you might find yourself going, wow, that was a lot of information. How do I process all of that? Know that you will be able to review this recording at your leisure coming in the coming days. But I also wanted to let you know this is really an overview. As we prepared for this webinar, the 3 of us talked about, there's so much we could tell you, right, about each of our disorders we work within. But this is an overview for you as you start to look at what are the commonalities between them. And so you will get a little bit of a bunch of information from each of us. So when we're going to transition over to talking about the autism spectrum disorders, but just to give you some statistics about epilepsy and autism, we know that about 30% of people that have one also have the other. When you look at comorbidity or co-occurring disorders, 30% of the people that have epilepsy and autism are together. When you look at, there are specific disorders that are diagnosed. They're generally, this category I'm speaking about is genetic related. You can see a list here of some of the examples of genetic disorders that have both autism and epilepsy as a component. So if you have tuberous sclerosis, you will more often than not be diagnosed with both of those along the way as part of that genetic disorder diagnosis. When we talk about kids, children, we know that children who have been diagnosed with autism, and part of their autism also has an intellectual disability or a disability that impacts their ability to learn and how they process information and how they adapt in learning situations. That if they have that intellectual disability as part of their diagnosis with autism, they do have a higher risk of developing epilepsy. So this is an interesting thing, like sort of what comes first. But what we know is about 20% of children who have autism and intellectual disability will develop epilepsy, whereas 8% of those who are diagnosed with autism but don't have an intellectual disability will be also diagnosed with epilepsy. So again, I'm giving you lots of numbers. I know that can be overwhelming. But what we also know is that if you're first diagnosed with epilepsy as a child, 5% of the people, the children will be diagnosed with autism. So you kind of can look at it both ways. What comes first, autism, and then what is the risk level for developing epilepsy, or epilepsy, and then what is their risk for developing autism. So that gives you a lot of information. The other thing I want to point out is at the bottom of some of these slides, and also at the end, you'll see all of our references. And so if you want to dig further into these sources, please feel free to do that. I'm going to turn it now over to Ellie Wilson. She's the executive director at AUSM, which we love to say, the Autism Society of Minnesota. So thank you so much, Ellie, for being here. And I'm going to turn it over to you to talk specifically about autism spectrum disorders.
Great. First thing I'm going to do is set my timer, because I have learned that the Epilepsy Foundation could work for NASA. They run such smooth webinars. I don't want to overstep my boundaries here. The other thing that I want to do is just thank you all for the opportunity to talk about multiple disabilities at once. It happens in our field all the time that we all sort of stay in our own lane. And as Amy just indicated, the lived experience of a lot of people with disabilities is that they have more than one. And in this case, there's lots of reasons to believe that children and adults in Minnesota could have any combination of the disorders that we're talking about today. So what a great opportunity. Thank you so much for having me. The way that this presentation is organized is really about better explaining autism and how it sort of appears across a very diverse spectrum. In 2020, if anyone tells you that they know what causes autism or they tell you they know how to cure autism, I want you to smile and nod and walk away slowly, okay? That's not necessarily what we're gonna focus on today, nor should it really be the focus of any professional presentation that you might see in 2020. At the Autism Society, we're kind of all about the social model of disability, which is how can a better understanding of this diagnosis lead to better understanding of the kinds of supports we can ask for? So if that's something you're interested in, we totally recommend that you reach out to us at Awesome. This is just the beginning of that conversation, but let's get started. Next slide, please. This is pretty much a repeat of what Amy just said, that in fact, if our disorders were a Venn diagram, there would be spots in the middle where our communities definitely intersect. We like to talk about the intersection with epilepsy and seizure disorders because that's really important. We also have intersection with other types of disabilities, including intellectual disability and ADHD, which Lee is going to talk to you about in a little while. The other thing that can be common with autism is a co-occurrence with sleep disorders. And the biggest one, the one I think that affects the most people with autism, young and old, is the presence of anxiety, which sometimes can be diagnosed as another co-occurring condition. Next slide. Thank you. This is the one you can pull up the whole graph and we don't, perfect. Okay, so this is a really good way to understand autism and really the diversity of folks who are on the spectrum. Many of you know that autism is one label and it describes people who might look and act quite differently from each other. This is one way to sort of help you conceptualize that. Now, if I were a psychiatrist, which I am not, I'm underqualified to be making diagnoses of people, but if I were going to test for autism, we can't test your genes and we can't test your blood. What we have to do is test different components of your behavior, how you move, how you think, how you express yourself, how you remember stuff, etc. Now, a typically developing person, and of course we don't use the word normal in my camp, right? Normal is a setting on a washing machine, not a description of a person. But a typically developing person would be like the green line that you see in the graph. Everybody's got their sort of relative strengths and weaknesses. We all have things we're better at and things we're worse at. But as far as the testing goes, look at how in that green line, all the scores kind of fall in that same horizontal part of the graph. You're not seeing a ton of variation in how people are testing in those skills. Someone who might have a sort of general delayed development might be the blue line. So we've got scores in these tests that are overall lower, but still not a ton of variability in those scores. Shout out to people who have delayed development. Of course, we know that people are capable of doing so much more than what these tests sometimes show, and these tests are timed. And the smartest person I ever worked with told me that all disability is a function of time. If you give people enough time, they can do a whole lot. But this is what the test scores look like. What we want to draw your attention to is this red line, which represents an autistic person. And look, they've got skills that are scoring so highly, scores that might be beyond that of their neurotypical peers. And then they've got scores that are below that of peers that might have broader disability. The point is there's no pattern, right? This is a real disordered way for the brain to develop. And what this is called diagnostically is splintered skills. So this is true for a lot of people with autism. They might have really profound skills in some areas, and they might have profound areas of need in other areas. The thing we want to draw your attention to is there's some kind of community language around high functioning versus low functioning autism. We at Awesome try to stay away from those labels because in most cases, when you actually look at what people need, their graphs look like this. And like, is this person high functioning or low functioning when you look at the red line? You start to realize that those labels aren't as meaningful as we intend, and so we try not to use them. Okay, next slide. One of the defining characteristics of autism is differences in how people interact socially, which is a really big part of how we communicate, right? One of the things that says in the DSM is that people with autism usually show differences in how they show reciprocal communication. Reciprocal means sort of back and forth. So it's very common when I hang with people with autism that, you know, I might say something to them and they might not answer me right away. Or on the other hand, I might be in mid-conversation and suddenly I'm talking to the back of their head because they have moved on, despite the fact that like I'm still going as part of a conversation. Those are of course highly integrated with social rules, but they also have to do with the tenets of communication. Many people with autism struggle with what we call nonverbal communication. So I bet a lot of you notice this now that people are wearing masks or having meetings over Zoom. Part of what you lose in that communication is the context of things like facial expression or gesture or sort of your body positioning. There's a whole lot that we communicate, not just with our words. And nonverbal communication is really hard for people with autism in many cases. So how do I receive your nonverbal cues and can I interpret them correctly? And also, do my nonverbals match how I'm feeling on the inside? One story that demonstrates this, I have a great buddy named Sam who I've known for a long time. Sam is about the most delightful guy you would ever meet. He has autism and he kind of talks in the same tone all the time and it's very happy. So I'll say, hi Sam, how are you today? And he'll say, Miss Wilson, gorgeous, how are you? He's a very nice guy to hang out with. And I'll say, Sam, how are you today? And he might say, Miss Wilson, I am pissed. And I will say, pissed? But Sam, your voice, your expression is not showing me that you're mad. You know, he doesn't necessarily know how to corral all of those parts of his expression. And so it's actually pretty great that he can tell us how he's feeling, though there is a mismatch in his sort of demeanor. Only about 10% of people with autism truly don't use verbal communication at all. So some people think like, oh yeah, I know someone who's nonverbal with autism. Again, that's only a small fraction. Most of the time, there's variability in these skills that's a little harder to detect. Knowing whether or not people are reading your social cues is a little bit harder to figure out, yet it's a thing that really defines the autistic experience for a lot of people. Next slide. The other sort of defining characteristic of autism per the diagnostic criteria is something called restricted repetitive behaviors. In other words, autistic people tend to sort of like things a certain way. They like to do things a certain way over and over. Sometimes that takes the sort of form of repetitive speech or movement. So someone might rock or pace back and forth or flap their hands in a certain way. Some autistic people use certain words over and over that really don't necessarily align with the context of any particular conversation. That kind of reliance on repetitive stuff, that's a pretty big indicator that autism is a player at the table. One thing that a lot of autistic people describe is that this sort of high need for sameness also gives them tremendous anxiety about doing something new. So if I have been to, you know, the Target in Richfield, that's the closest one to my house, that's the Target I go to all the time. If you send me to the Target in Roseville, that Target's a little bit different, and it's hard for me to generalize what I know about my Richfield experience to how I need to apply that to my Roseville experience. What that ends up looking like is that autistic people oftentimes really like stuff the same. They love routine, you know, and this is a broad stroke. I don't want to paint too broadly, but in general, we really love routine. We like rules. We like highly structured activities, and we really like to sort of stick to the script. And that's something that shows up in a whole lot of people with autism. Honestly, I think it's relatable. A lot of us are change averse. Imagine if that aversion is really sort of more disruptive to how you process, think, and communicate. Next. This one is, again, the clinical language leaves a little to be desired, because in the actual DSM, it says people with autism have a really hard time with imagination. And that's not really true in the way that most people use that word. When we say that people with autism have a hard time with imagination, oftentimes what we mean is that they can have low theory of mind. Theory of mind is essentially the ability to put yourself in another person's shoes. It's a cognitive process. It's not the same as empathy. It's not the same as kindness. Everybody that I know with autism has those characteristics in spades most of the time. Really what we're talking about is the sort of cognitive ability to imagine the perspective of another person. So a really great way to talk about this, a lot of people worry about autistic children and adults who might wander or who might elope. This is something that we deal with in our community a lot. And oftentimes when someone elopes, the natural response is to think, what are they trying to escape from? What are they trying to get away from? Is something bad happening to them wherever they were? But I want you to think about it this way. What if you had such low theory of mind that you can't necessarily imagine the perspective of another person? You can't imagine that they see things differently than you. If I know where I am, why doesn't mom know where I am? You have to sort of have that fundamental understanding that someone has a different mind, a different set of information than you have in order to prompt that kind of communication. This is something that's really tough for people on the spectrum. It also means it's hard for them to receive. And perspective taking, or rather inferring what other people mean, can be really hard. So if I take a kid with autism to the pool and I say, there is no running, what I actually mean is I want them to walk, but they have to infer that that's my intention. If I say no running, there's any number of actions that technically are aligned with that rule. You can skip, you can hop, you can slither, you can eat a cheeseburger, whatever. What I actually intend to say is, I'd like you to walk, please. And that's why we have reliance on such direct communication when it comes to people on the spectrum. Let's do the next slide. Of course, this is one of the most favorite things that people like to learn about when it comes to autism. It's not specific to autism, but it's something that affects a lot of people on the spectrum. Many people on the spectrum have either overreactions or underreactions to a sensory experience. Now, when I was very young, a large yellow bird taught me that we had 5 senses. I don't know if that yellow bird taught you the same thing. As much as I love that bird, it turns out he's misinformed. We actually have 8 different senses. I won't make you go over the 5 that you know, but your 6th sense is your vestibular sense. That's your body's sense of balance. Your proprioceptive sense is your 7th sense. That's the thing that helps you differentiate between a tickle and a squeeze, right? Proprioceptive input is all about pressure on your joints and on your muscles. And then the newest kid to the block is the interoceptive sense. That's your ability to not just take cues from the outer environment, but rather to take them from your inner environment. What does it feel like to feel hungry? What does it feel like to feel exhausted, or to have a sore throat, or even to feel anxious? Many of you might relate to the fact that you don't know that you're anxious until you realize your heart is pounding. That's your interoceptive sense at work. And many people with autism either have an incredible oversensitivity to one of these things, whether it's smells or sights or sounds, or they seek out a lot of input from one of these things because they actually aren't getting enough of it from their typical environment. So when you think about kids with autism or adults with autism who benefit from weighted blankets, you know, that's because they might not be getting enough proprioception from their typical environment. And in order to feel sort of regulated, they might need a little bit of that input to be able to kind of move on to the other functions of their brain. Which brings me to my last point, the last slide that I have for you today. which is about executive function. And this is going to be a great segue to our friend Lee, who's going to talk to you about ADHD, because there's a real bridge here. But executive function, again, not specific to autism, is how we think about our brain's incredible capacity to do more than one thing at once. It's kind of, your executive function is essentially your ability to use multiple functions of your brain at one time. And to kind of use them in a way that is coordinated and cohesive. Those on the spectrum who have low executive function, which is a trait we share with many of our counterparts with ADHD, means that it can be really hard for us. It can be hard for us to complete a task because we might not be putting the steps of that task in sequence. That can really look like we're not paying attention. If we don't necessarily know the first step, it can look like we're refusing something when really we just can't infer that the first step is to whatever. It also affects our ability to manage time. So I have a ton of autistic colleagues and friends who don't do the best. Even they love a schedule, but they need a little wiggle room when it comes to time management and transitions, because those things can be really tough. So the last thing I'll say before we kind of move on to talking about ADHD is a comparison. A lot of people will say, my person that I love has a really hard time paying attention at school. Do they have autism or do they have ADHD? And first of all, the answers to that require a little bit more knowledge. But basically what we say is that when an autistic person isn't paying attention, it's not because they can't. It's because they don't know what to pay attention to. They might be distracted by the sensory environment. They might not recognize the social cue that if all the other children in the class are facing forward listening to the teacher, that they are also supposed to face forward and listen to the teacher. There's some social inference in there that isn't necessarily happening. Whereas a child with ADHD can have more challenges that are directly associated with their ability to attend in the first place. So that's just one way that we have, some confusion that oftentimes happens between these two things. And I think it's a perfect reason to sort of pass it along so that we can talk about ADHD next. Thank you.
Thank you, Ellie. Just to give you a little bit of statistics about epilepsy and attention deficit disorder as we move into that with Lee, what we know in our statistics as we've looked at studies is that 40% of children that have epilepsy are also diagnosed with ADD or ADHD, and about 20% of the adult population that we serve that has epilepsy also will be diagnosed or have been diagnosed with ADD or ADHD. And I know Lee's going to give us a lot of great information, but some things to think about when you think of these two as a dual diagnosis. And I think you could put autism in here as well, as Ellie has shared, is that there can be impacts on learning, the ability to process information, the ability to adapt to different learning styles and different things like that. And there are also potential impacts on mood and behavior, how they perceive the impact of their diagnoses on their world or their experience with the world, or even how they perceive people will interact with them, or will how the outside world sort of handles what their diagnoses are towards them, right? And so we know that we might have things like anxiety and depression that exist also that we aren't even talking about today within these dual or triple diagnosis, if you will. Just a reminder to everyone on the webinar, you can open up your Q&A at the bottom and put any question that you might have within there, and we will answer that at the end. I also just want to do the disclaimer that I didn't mention at the beginning, and that is that we are all nonprofit workers, professionals, and so when we talk about each of these disorders, we're not coming from that medical perspective, right? That would require a medical diagnosis and a medical professional. So just want to put that out there as well. But I want to turn now to Lee Garrels, and she is the Research and Development Coordinator at ADAM, which is the Attention Deficit Awareness of Minnesota. She wears lots of hats at that organization and probably should add to her name. So thank you, Lee, for being here. I'm going to move us forward into your slides.
Thank you for inviting me, Amy, and Ellie, great segue into my spot here. I want to tell you just a little bit about our organization because we're different from the fact that we are not a direct service provider. When we started in 1995 and we were just covering Stearns, Benton, Sherburne, and Wright counties, we found out that we didn't need another direct service provider. What we needed was somebody to coordinate all the healthcare, mental health care providers that worked with ADD, that's what it was called then, and all the support services that were available, because none of the professionals, none of the support services knew about one another, and they didn't know how to refer people. So I co-founded it with a good friend. We both had done ADD support groups in St. Cloud, and we came up with ADAM, which is just strictly information and resources. And our job was to go out, gather all this information, bring it in, organize it, and get it right back out in the community, particularly to healthcare and mental health care people, so that they knew how to refer their clients and their patients. And then in 97, we broke away from the YMCA. We formed our own nonprofit, and we added 3 more counties a couple of years later: Mille Lacs, Todd, and Morrison County. Next slide, please. So let's talk about what we know about ADHD. And Amy and Ellie did a really good job in that describing the overlap that we have between these 3 different conditions. And Ellie's slide on executive function is perfect, because that's what we're talking about with ADHD. We know that about 11% of the kids in the ages of 4 to 17 have ADHD. Those are numbers that were compiled by the CDC, so we go by them pretty much. And also about 4% of adults have ADHD. We know that there are the 3 types. You have the hyperactive impulsive, you have the primary inattentive, that was what ADD was, and now you have the combined types. You've got the inattention and the hyperactivity. That's really one of the more common types. The other thing that we know now, so when my son was diagnosed at 8, he's 42 right now, and he was just classified as the combined type. But research has shown that they think you kind of float in and out of all of those categories during your lifetime. May depend upon what type of job you have, may depend on what type of task you're doing, but you're not just locked into one descriptive category anymore. We also know that it can affect every aspect of a person's life, and that depends a lot on the severity. ADHD can be anything from mild to where you don't really need a lot of accommodations. You might be able to just control it with lifestyle changes. You may or may not need medication. They have found now that there are some foods that will trigger your ADHD. And so if you stay away from those foods, that might help you if you have just a mild case. But it's not like the Feingold diet that was out many years ago, and there was a lot of controversy over that. However, it can be very severe, and that has to do with how many other conditions, how many other comorbidities that you would have with the ADHD. There are so many different conditions or disorders that can go along with ADHD. And lots of times we only focus on the mental health part, the anxiety, the depression, the OCD, conduct disorder. And we forget that there are a lot of medical conditions, just like what we're talking about here today, that can go along with ADHD. And so when you are trying to decide what might be going on, there are many different areas that you have to look at. We also know that there are certain things that people who have ADHD have in common. For example, Dr. Russell Barkley talks about time blindness, and Dr. Ned Hollowell talks about now and not now. And it will get better as they get older, as they learn to compensate, as they learn how to use apps and different strategies to compensate for time. But time is something that you cannot teach. Time is something that we feel. So for example, if I would say to you, I'm going to stop in this store and I'll meet you at the car in 20 minutes. I don't really need to watch my watch or my cell phone for that. I can kind of feel when 20 minutes are up and to meet you back at the car. That's the capability that people with ADHD just really don't have. And it's not a problem so much when you're 4, 5, and 6 about being able to tell time and be on time, but it can get to be a real problem when you're adult and you have a job and you have responsibilities and you just don't seem to ever be able to be where you need to be. Luckily nowadays there are many apps, there are devices that kind of look like Fitbit watches that you can acquire, and they buzz and you can set them for all kinds of things. And I will say, as the younger, the high school, college age people in their 30s and 40s, they really do like those devices. Also, there is a sense of that parents need to know that there is a delay in their development of kids. So in other words, you have chronological age with ADHD kids, you have developmental age with ADHD kids. And the prime example that always seems to get everybody's attention is talking about driving. 16, everybody wants to get their license, but there is a 3 to 5 year developmental lag. And so you need to keep in mind as a parent that means that your 16-year-old who wants to drive and has ADHD actually may be developmentally more of a 11 to 13-year-old. And you don't give 11-year-olds or 13-year-olds cars to go out and drive up and down the streets. And so when you have a child with ADHD, you have to be aware of this because, for example, I'll just use my own life. When my son would get invited over to a friend's house, and if his friend was, right where he should be chronologically, and they're going to be out running around, I needed to make sure that mom knew that my son wasn't reliable in that area, that you couldn't just let him go with her child and maybe roam the area, or run down to the neighborhood store to get a treat or something like that, because he just wasn't there developmentally. And that can be a very stressful and a very problematic aspect of an ADHD child's life. Also, each person's ADHD is different. And so you have to keep that in mind when you're looking for professionals to work with. So the person who might work for me may not necessarily be the right person for you. That's one of the nice things about support groups, I think, is that you can get a feel as to who the professionals are in your area and kind of how they operate and why the person in the support group chose that professional. It does take a lot of legwork, I think, in order to find the right, what I call your ADHD team. And that's going to be your physician or your pediatrician. If it's you're dealing with school, the teacher or teachers, and it may have a therapist thrown in there too. And it's a lot of coordination and it's a lot of communication between home and school, because ADHD does take a lot of time. It is a lot of work, and it can be exhausting some days. But at the same time, I don't like to just focus on the doom and gloom that I think sometimes we get frozen into, is that there are so many resources out there right now that people can draw upon, and a lot of them are free. I would say about 80% of them are free if you use the internet. You can get a lot of learning, a lot of information. And so if you think you have ADHD, we already talked about that you need to really work with a professional who understands the condition, all the overlaps, all the different things that can occur, all the different comorbidities, and that can be difficult. A lot of doctors don't feel that they're equipped to deal with ADHD. And also, you need to remember there is no cure for ADHD. It is about getting an accurate diagnosis, a sound treatment and management program, and also learning to educate yourself and your entire family, and that means grandma and grandpa and aunts and uncles and cousins, about ADHD. And then your goal is, if you have a child with ADHD, is to teach them how to learn to be an advocate for themselves, because they too will have to continue to learn about the disorder as they go through life. And as I said before, you need a good support group, you need a willingness to continue to learn, and to keep expanding your resources. One of the things I like to stress to parents, it's much easier to look for resources when your life is not in crisis or chaos, so that you've got time to check things out. And then when you slide backwards with ADHD, because you are going to do that, you can go right to your ADHD toolbox, your ADHD library, and find the resources that you have on hand that you think might work for you. And then at the end here, these are the 4 resources that we recommend to everybody through our nonprofit, whether you're just starting out on learning about ADHD or whether you've been living with it for years. And the reason we like these resources, they have good review panels, they have good advisory boards, they have people who are well established in the field of ADHD. Some of them are international speakers. Next slide, please. And this is just how you can get in touch with us. We're just about done upgrading our website and event calendar, and because we are an information and resource organization, we have a ton of information. It's free. It's available 24/7 all year round. We just established a newsletter in May, and this is the link to the archive. I really encourage you to go take a look. The newsletter is for getting you in touch with resources. It has a pretty wide variety of information. And then if you would like to get on our emailing list so that we can keep you up to date on what's happening with like workshops such as this that are virtual, or what's happening, some hot breaking tip on ADHD, there's our email address. We do not share or sell our email list. You can request to be on it and request to be off of it at any time. And thank you.
Thank you, Lee. As we slide down into our question and answer time, I just want to remind everyone that you can type in your questions. And the way we'll do our question and answer is I will just read the question, and whoever it seems to be directed towards, I'll let you know, ladies, which one of us should be answering it. So please make sure that you put those into the question and answer time here. The first question we have is it possible to grow out of ADHD some? Since my daughter hit puberty, she seemed to be calmer. It's still there, but it seems she either can control it more or she's growing out of it. Lee, do you want to answer that one?
I will do that. Now, you have to keep in mind, I'm not a medical person or anything like that, but yes, they can improve with time as they learn to cope and get management skills, and they have more successes. And it does really depend on the severity of the ADHD, because somebody who is a mild case is going to probably have a better time making social relationships work for them versus somebody who's really more at the severe end of it. And they can get in with the wrong crowd because they've had so much rejection. But yes, if you're working on it and you're learning about it, it should get better for you as they get older.
Can I add something to that?
Yeah, you bet, Ellie. Yep, go right ahead.
You know, one thing we talk about a lot at the Autism Society, which again is not necessarily specific to the question about ADHD, but with these disabilities that can be rather invisible to sort of naked eye, one thing we talk a lot about amongst autistic adults is something called masking, which is essentially not that your needs have changed, but that you get better at hiding what your needs are. And, you know, for some people, hiding their needs can be seen as desirable because it might help you minimize how much attention you are attracting due to your disability, which is an area of great insecurity for a lot of people. But the truth is, we have to be careful that when we think we're seeing improved symptoms, what we might be seeing is improved masking, is I'm getting better at hiding my needs from other people. From a disability advocacy perspective, I know Amy and Lee would share my concerns. That's not the direction we want to go. We want to make sure that people's needs continue to be met in whatever age appropriate way they need it, and that we don't necessarily jump on the bandwagon too early that something might be cured or resolved, when really it's likely more an evolution that's happening within a person. Does that seem fair?
Yes, yes, that answered what I was going to say as well. Thank you so much for that, and thank you for that question. Next question that we have is there a correlation between ADHD and seizure frequency? I'll start with that one just to remind you, as non-medical professionals, and with each of these disorders being very individual based, they're an individual experience, right, for each person. What we know is what you might be seeing is if you're diagnosed with both and you're looking at seizure frequency being increased. We didn't really touch on this, but one of the things that I know that we talk about with our clients that have both is, what are you using for medications and things like that? Like, are talking to your doctor about when you have both or all three of these and you're taking medications, how are they impacting each other, right? So there could be some ADHD meds out there that once they're started, seizure frequency might go up. And that is a side effect of that med for the ADHD. And so truly, when we speak to clients about it, it's really about, that knowledge that you have gained from your doctor, your pharmacist, making sure that as you are trying different medications, trying different treatments, things like that is all taken into consideration. And again, it's a really individual sort of experience. So for some people, they might have an increase in frequency with their ADHD. It also might be life, sort of where they're at in their season of life. So we know that seizure frequency increases during puberty for many, many children, simply because of the hormonal sort of imbalances and fluctuations that impacts how their brain is able to handle that, and then how their brain is able to control the misfiring and things like that. So Lee, do you have other things that you can think of with that one?
No, you summed it up perfectly.
Okay.
I like it. So Amy, the point
you bet.
About puberty, or honestly
Yes.
any other sort of major developmental phase being a good time to reassess what those needs are. Because one of the things that oftentimes does happen in our community too is that you kind of get your package of strategies that work really well for that age leading up to puberty, and suddenly puberty is the great disruptor. That's not specific to any of our three disorders that we're talking about today, but not just biochemically, but also just sort of socially and other things. It's oftentimes the time when you can predict that you'll have to go through sort of a reevaluation of the landscape.
Right, absolutely. Thank you for that. One other question that has been raised is, how are each of these disorders diagnosed? What's the testing sort of part of that? And I can start with epilepsy. I mentioned EEG scans. One of the things in the epilepsy world that can be difficult in diagnosis is, unless you're actively having a seizure, in an EEG test, it's not going to show up. So what we have a lot of families that are dealing with, whether they're an adult with epilepsy or having seizures, or a child, is the reporting to the doctor as to what's actually happening. So definitive testing is done through EEG, or that tests the brain waves, the electricity in the brain. Is it firing correctly or misfiring? Oftentimes there are scans that are done just to see if there's something structurally that is happening that is causing that misfiring. And then one of the biggest components right now with individuals who have epilepsy is how they self-report can include things like videos. On smartphones are a great thing, right? So one of the ways that many of our doctors will say, if they haven't caught a seizure, like while you're in the office or you're in the hospital, a seizure happens, having your caregiver or whoever is with you record what is happening, sending that to them. And we have a lot of doctors like, I've learned a lot about my patient because I'm now seeing what I couldn't see while they were in the doctor's office. And so diagnosis is EEG and scans, but we also know there's that component of self-reporting too that happens with epilepsy. Can both of you just talk a little bit about what testing is like if you're suspecting you have a child or yourself are dealing with one of these other things as well?
Yeah, I can go first. In the case of autism, we actually have kind of a unique situation, although Lee probably shares it for ADHD. In the community of autistic people, diagnosis can happen with a doctor or with a medical provider, or it can happen at school. So you'll hear people talk about either a medical diagnosis or an educational diagnosis. It still just so happens that the average age of diagnosis for autism in the state of Minnesota is around 5 years old, and that's oftentimes because kids are in social classroom settings for the first time. The criteria that people use are the same, and again, it's not like a blood or genetic test. It's a series of sort of behavioral and communication observations that happen from a credentialed psychologist or a doctor. The pain in the neck in our community is that sometimes you have an educational diagnosis, but that doesn't qualify you for medical or social services, or vice versa. And that is just the worst. We're trying so hard to get to a place where that's not such a problem for so many families and individuals. What about you, Lee?
And for ADHD, it requires a medical diagnosis. Schools cannot diagnose ADHD. They can recommend that maybe you see your physician. They can suggest that this is what's going on in the classroom, but it does require a medical diagnosis. Now, there's no lab test that you can do for that, no scans. It involves a thorough physical, it involves a thorough history, trying to go back to see, did anybody else have these traits, these characteristics, these symptoms in your family? And the reason you want a thorough physical, there are a number of medical conditions that can cause a child, or an adult for that matter, to be off task and inattentive. And ADHD is kind of down on the list. It's not always the first thing that they go to. Also, from psychologists, there's a number of evaluations and different types of testing that they can do that gives them feedback about whether or not you meet the criteria for ADHD. And depending on where you go, it may be just your pediatrician or your family practitioner who is doing the testing, and they will do some of these evaluations from a psychologist. However, if you're at a bigger facility, they may actually have an ADHD clinic. They may have an ADHD team, and that is made up of psychologists, social workers, educators, physicians. They'll run some of these tests, and then they sit down and they compile all their information, and then they will give you a diagnosis.
Thanks for, yes, that's great information on all three of these and how they're diagnosed. We are just a few minutes from being done, so I want to thank you. I think we've been able to answer the questions that have been raised here, but know that we're going to go through a couple more slides that will help you as you afterwards if you have questions, things like that. So from the perspective of EFMN, or the Epilepsy Foundation in Minnesota, we do have an information services program where we have one of our staff members dedicated to simply answering questions that come through. One of the things I will tell you during this time of being all virtual or online is we have really worked on how do we connect people to the other resources they might need, because we do know that we might get a question from someone who has epilepsy that's related to another disorder or another area of their life. So know that it's very customized. And I would say that each of our organizations have this service. And so please feel free to utilize any one of the three organizations' websites to get more information or specific to your questions. This just tells you a little bit about EFMN, our contact information here, and then references throughout. I want to finish with these three websites. These are the websites for our three organizations. Again, know that you can reach out, check out our websites, reach out through our websites to have any other further questions answered, or if you're wondering about how do I go about the process of starting to ask the questions of should my child be evaluated for any of these, we can help you with that as well. I want to end by saying thank you so much to Ellie and Lee for joining me in this first of webinar where we've collaborated together. There's so much we could share even more, but thank you both so much for being here.
Yeah, it was a pleasure. Like I said, this is such a cool thing to get to talk about multiple communities at once that's so aligned with the lived experience of all of our communities. And I can see many of you can say like, wow, this is tricky. The overlap can be really tough. You can't really go wrong if you reach out to any one of our organizations. We work so well together, and we're happy to sort of start you on any part of the path that you might need. Then we can just help you take it one step at a time.
Absolutely.
It was great talking to all of you today, and I just would reinforce what Amy and Ellie have said. Anytime you're maneuvering just one of these disorders, it's tough. You put more than one in there, and it is very, very tricky. So the more information, the more resources you have, the better off you're going to be.
Wonderful. Thank you all for joining us today. Again, just to remind you, you will receive in a few days a certificate of attendance. We also will send with that in a feedback form. We welcome your feedback on this webinar, and then you will be able to navigate to our recording of this webinar in the next few days. Thanks, and have a great rest of your day.